Purva, shall I start?
Yes, sir, we can start.
Okay, thank you. Thank you, Purva. So, good evening to all of you. As usual, I will start with a ultra short case today first, then followed by two long cases. Okay. Can you see my slides? Are you able to see my slides?
Yes, sir.
Okay, right. So, this is a 25-year-old man who noticed loosening of chapels from the age of 5 years. It was really non-progressive, has no other complaint. But he has come now after 10 years since his friends are making fun of him. That is the indication for his present consultation. Let us see the patient's video. The findings are confined mainly to the lower limb. Proximal muscles were normal. It's got flowing of the maybe hammer deformity is also there. EHL was weak. Adductor hallucis was weak.
Small muscles. The clock and deformity.
Introducer also weak. Toe flexes were quite normal. Also plantar flex is normal.
Good. If long figure, that's also good power. इसको ऊपर कर देना.
Those flexes were weak bilaterally, especially everters were more weak than inverters.
That is good.
That's inverters, which is good power. At good power.
But evasion, keep it like
Evasion is weak. See, evasion is grossly weak.
straight.
Straight ಮಾಡಿ
Knee extensors normal power.
ಇದಕ್ಕೆ straight ಮಾಡಿ.
ಅದನ್ನು ಕಾಲೆತ್ತಿ
Knee flexes normal.
Similarly like this.
ಅದಕ್ಕೂ ಕಾಲು ಹಾಗೆ ಮಾಡಿ ಅಗಲ ಮಾಡಿ
Hip abductors normal power.
Good power.
Hip extensors also normal.
Not 4+5. Okay. What is between 4% 5? Like that.
Hip abductors normal.
ಸರಿ ಮಾಡಿ ಸೀದಾ ಮಾಡಿ
Knee jerks are well elicited. Ankle jerk absent. Touch pain sensations were normal. Vibration normal.
Vibration is there.
But he's made some mistakes in the joint position sense in the big toe.
Now. Up now. Now. Now.
He made occasional mistakes. And this is how he walked. With bilateral foot drop.
See that. See what is
He could not squat with foot right angle pressed on the floor. It was kept elevated, indicating a contracture of the right endo Achilles. So on examination, contracture of the right endo Achilles. He could not squat with the right foot flat on the floor. Weakness of both dorsiflexes, EHL, FHL, and everters, grade 1. Normal power of plantar flexes and toe flexes. Weakness of adductor hallucis and introshi. DTR absent, angle check bilaterally, knee checks normal. Sensation impaired, JP sensor on both toes. So what is your likely diagnosis in this patient? It's a short case.
HMSN.
Pardon?
HMSN.
HMSN, yeah, CMD, cyclodemic. It's a straightforward case. Now, this is a conduction. It shows absent potential from the con peroneal nerve and the tibial nerve distally. Even though tibial was clinically not affected, maybe small muscles might have been affected. That is why where the tibial sand is also, that is why the potentials are not picked from the tibial nerve. Upper limb is normal. FAV latency was absent in the lower limb and the con peroneal because of the low amplitude. And So most likely the CMD. So I think this is simple, straightforward case. So any questions in that case? Proper case is going to come. Okay, this is a typical classical variety of CMD. We need not even do a genetic test to confirm the diagnosis because long duration, static, almost static, the classical picture of CMD. Okay, shall I go to the next case?
Is it CMT 1 or 3, sir?
No, I have not done a genetic test in this patient.
Clinically, probably CM2.
He has got sensory is hardly an effect, mainly motor involvement. So the classification has never changed, no? But I don't know the recent classification. Now it's only genetic classification is coming up rather than the CMD 1, 2 and all gone now. Okay. Shall go to the next case. It's a long case. The story of the 34-year-old female. She's an old case of diabetes mellitus since the age of 20 years of age, first detected in the gestational period. Her present complaint started 7 years back as loosening of the chappals from both feet, 7 years duration. 1 year later, she noticed paresthesia of the dorsum of the right foot, which extended up to the ankle. 1 month later, she noticed similar paresthesia of the right hand, which later ascended up to the shoulder. For last 2 years, she noticed imbalance while walking. She was investigated and treated about 7 months back in the hospital with the IV steroid. However, for the last 6 months, she noticed difficulty in using her hand in the form of difficulty in cutting vegetables. Almost the same time, she noticed severe pain over the back of the neck, radiating in the both shoulder region, as well as a bursting type of pain over both feet. This is exactly the word she used. So I think we'll go back to the history once again. Detected to be diabetes, gestational diabetes. Her present complaint started 7 years back as loosening of the chappals on both feet. 1 year later, she noticed paresthesia of the right dorsum of the foot, which extended to the ankle on the right side. Then 1 month later, she developed paresthesia in the right upper limb in the hand, which later on extended onto the whole of the right upper limb up to the shoulder. For the last 2 years, she noticed imbalance while walking. Then, for the last again 6 months, she noted difficulty in using her hand in the form difficulty in cutting vegetables. Almost the same time, she noticed severe pain on the back of the neck radiating to both shoulder region, as well as bursting type of pain over the both feet. Okay, there is a story in the patient. And let us see the positive findings in this patient. Cranials were low. Bone was normal in the upper limb. Look at the power. Muscles were normal power. This is normal, even though she's incompetence. Biceps is normal. Recessions is normal. Finger is also normal. Finger flex is normal. There is no finger nose incoordination. There is no, does not appear to, pseudoarthrosis could be made out. Lower limb, there is hypotonia. Inflection normal power in the lower limb. Knee extension normal. Hip abduction normal. Adduction normal. Hip extension also is normal. Dorsiflexion was mildly weak bilaterally, but AHL was weak.
ഇത് പിടിച്ചേ.
It's definitely weak.
ചവിട്ടിക്ക്.
Plantar flexion normal.
മതി.
The only muscle weakness EHL and mild weakness is dorsiflexus. Reflexes, all reflexes were absent.
ഇത് അടിച്ചേ, വിട്ടേ.
Even with the reinforcement, they were absent. Knee jacks were absent. Plantar indefinite. The sensory findings are mainly sensory system. She could not feel, touch the whole of the upper limb.
ഒരു മിനിറ്റ്.
Neck also she was not able to feel. On the face she was able to feel. Occasionally she felt on the left upper limb, 1 or 2. Most of the time she did not say 1. The abdomen, however, she was able to feel. In the thigh she is able to feel up to the knee, but not below the knee. There she is not counting.
മുള്ളെന്ന് വെച്ചു. മുള്ള്
Then does the pain compared to the pain, the front end of this thing and the pin prick?
ഇതാണെങ്കിൽ മുള്ള്. അങ്ങനെ പറഞ്ഞു. കണ്ണടച്ചു.
He is telling correctly the pain. But in the arm, she is not able to feel, but forearm she is able to feel a little bit. No, the other forearm she is not able to feel at all. The hand and arm she is able to feel.
അവിടെ മുട്ട്.
There he is not able to feel very much. The arm she is able to feel. That area she is not able to feel. In the fingers also it is not able to feel. She is able to feel, but not in the forearm. In the arm she is able to feel a little bit.
കൂടുതൽ.
Taking it down, she will tell when it's able to feel.
വേദന.
There she is able to feel, not in the forearm.
ഇനി വേനെടുക്കുമ്പോ പറയണം. ഇപ്പൊ ഡള്ളാണ്. വേനെടുത്താ പറയണം.
There she is able to feel the pain.
ഇതും തമ്മിൽ എങ്ങനെ?
But even though she is able to feel the pain in the hand, it is less than that of the face.
ഇതും തമ്മില്ല.
The abdominal wall she is not able. Abdomen she is not able to feel.
അവിടെ അറിയും.
Both the feet it is lost up to the knee.
അറിയുമ്പോ പറ. അറിയാം.
There is able to feel the pain.
നോക്കുമ്പോ നോവുന്നില്ല.
But comparing with the thigh and the neck, it is
അവിടെ നോവുന്നുണ്ട്. ഇവിടെ നോവുന്നുണ്ട്.
there she is able to feel.
നോവുന്നുണ്ട്. ഇല്ല. 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 ഇല്ല.
Vibration she is not able to feel the hand, able to feel on the elbow. She is able to feel. In the shoulder he is not able to feel.
ഇല്ല. ഇല്ല. ഇല്ലെങ്കിൽ തന്നെ പറയാം.
Knee it is lost. He is able to feel little bit.
ഇപ്പോഴാ
Toes it is lost.
ഒന്ന്
And superior spine she is able to not able to feel.
അവിടെ അറിയുന്നില്ല. ഇത് നിൽക്കേ. ഇത് ഒട്ടുമില്ല.
She is not able to feel. But the shin she is able to feel little bit. Mild feel on the left side also she is able to feel little bit.
ഇവിടെ ഇപ്പോഴാ
Joint sense, upper limbs lost.
ഇപ്പോഴാ ഇപ്പോഴേ
Totally lost.
അറിയാൻ പറ്റില്ല. അങ്ങനെ പറയാൻ പാടില്ല. ചുമ്മാ പറയാം. ഊഹിച്ച് പറയാം. ഇപ്പോഴാ
Again lost. In the elbow, however, she was able to feel the joint position sense.
ഇപ്പോഴാ ഇപ്പോഴേ
Elbow, shoulder also she is able to feel.
ഇപ്പോഴേ ഇപ്പോഴേ
The lower limb, toes it is absent, ankle it is absent.
ലൂസാക്കിയത് ഇപ്പോഴേ അറിഞ്ഞൂടാ.
It's also lost over the knee.
ഇപ്പോഴാ
They made mistakes in the knee joint motion also.
ഇപ്പോഴേ ഇപ്പോഴേ ഇല്ല.
is impaired, there is not able to feel. There she is able to a little bit. There she is able to do much more better than below. She could not stand on heel. The dorsal flexion was incomplete, but she could stand on toes. She could get up from the squatting position. And Romberg's was grossly positive. She could not stand with even wide effort also she could not stand. She walks cautiously with wide pace, looking at the ground. Tandem walking not at all possible. So cranial examination, all normal. Motor, upper limbs, tone normal. Power, all normal. Lower limb, tone, hypertonia, both lower limbs. All normal except for the weakness of dorsal flexation of the angle, dorsal flexus of the angle and the both EHL. The detail in the upper limb all absent, lower limb all absent, abdominal reflex absent, plantar mute bilateral. Now sensations, I'll come to these, that's the most important finding here. Touch upper limb impaired over both upper limb and over the neck. It was felt over the elbow occasionally, otherwise it's not able to feel. Only slight impairment of touch over the abdomen. The lower limb lost below knee. This is the area of touch sensory loss. The density of the color indicates the density of sensory loss. All are lost except the abdomen, it was less. The upper thigh, she is able to feel the touch sensation. In the elbow also, she is able to count on the left side. All other areas, she was not able to appreciate the touch sensation. Coming to the pain, upper limb lost over both forearm. That's the maximum in the forearm. Only mild impairment of both arms up to the neck, as well as both hands and fingers. The upper limb, maximal losses in the forearm, other areas, mild impairment of pain compared to the face. The abdomen impaired over the abdomen. The lower limb lost below knee. There is mild impairment on the thigh. So if you look at the distribution, the maximal loss is on the forearm and the upper limb, below knee in the lower limb. Other areas it is impaired in comparison with that of the face, but able to differentiate between the back of the pin and the tip of the pin. Now coming to the vibration, the upper limbs impaired over both hands and fingers, impaired over both shoulder, but elbow she is able to feel a little bit. The lower limb impaired over both ankles and toes, able to feel slightly over the shin, but lost in the right anterior superior leg spine, mild impaired over the left anterior superior leg spine. So this is the vibration area loss. Maximum in the hand and the shoulder and in the feet. Less in the knee and also lost in the anterior superior leg spine. This is the area maximum of the feet and the anterior superior leg spine. Less in the knee. Here also shoulder it is lost. Hand it is lost. Less in the elbow. JPS sensation upper limbs impaired over both hands and fingers. Normal in both elbows and shoulder. In the lower limb, impaired over both ankles and toes, impaired over both knee, but hip it is normal. So here you can see the JPS is lost on the hand. The elbow and shoulder they are able to feel. The lower limb it is lost in both toes, ankles as well as in the knee. She can walk on toes but not on heel. Thrombus is severely positive. Slow stroke and the walking not possible. So where is your localization? If any doubts in the finding, you can ask me.
Sir, is it predominantly sensory radiculoneuropathy with a mild motor involvement?
Perfect. Yeah. So
There's a patchy sensory loss also. So additional ganglionopathy cannot be entirely ruled out.
radiculopathy also can be patchy, need not necessarily be ganglion. Sensory radiculopathy and ganglionopathy behaves exactly the same clinically. So any other thought, what diagnostic, any other opinion from anyone?
Sir, she had a cervical pain, sir.
She had pain in the cervical region radiating up to the arm, as well as bursting type of pain over both feet.
So can it be localized to cervical cord, sir? Myeloneuropathy, a possibility, sir.
No, but actually there's no evidence of any pyramidal lesion in this patient. The sensory findings also does not conform to a tract involvement. So
Overlapping neuropathy can mask the brisk reflexes, sir, because LMN overrides UMN.
yeah, but we should have evidence, no? Agreed with that point, but we should have evidence of some suppose there is subgoing plantar for a sensory level. Then just because the pain is there, we cannot, because root involvement also can produce pain, ganglionopathy can produce pain, depending upon if that pain fibers are affected.
The distribution is most fit with the ganglionopathy.
More with the ganglionopathy, yes, okay. So you think it's a ganglioneuropathy, correct? But she has got weakness of both EHL and she cannot walk on heel.
Which
Pardon?
is a large and small fiber neuropathy. Bilateral large plus small fiber neuropathy. Neurotic
Correct.
patterns.
Yeah, that's correct. Bilateral large and small fiber neuropathy. You mean to say what type of distal symmetrical motor sensory neuropathy?
Doesn't fit into length dependent patterns, sir.
Yeah, it's not length dependent. So what do you infer by that? So you mean to say something like a CADT?
Mononeuritis multiplex like
Yeah,
presentations.
correct. Okay, that's correct. Mononeuritis multiplex with predominantly sensory nerves are affected. Correct. But it's not, if you look at the distribution of the sensory loss, it is not fitting with that of a nerve pattern. To call mononeuritis multiplex involvement, either if it is motor or sensory, it should be in the distribution of a nerve distribution. Here it is not like that. See the arms, see the forearm pain is totally lost. The arm she is able to feel. And the anti-displacement vibrations lost in the shin she is able to feel. So really a patchy type of involvement. So it's not fitting for the multiple nerve pattern. Convergent part, I agree with it, can fit in with the convergent parts, but the sensory findings are not fitting with the mononeuralism.
But radical also it is not fitting, no, sir. L4 radiculopathy, if you say over the shin, and there she's able to feel the vibration. Anterior superiorly expand, she's feeling
Correct. Yeah.
not,
Yeah.
she's not feeling. But
Correct.
at the
Exactly.
same time, she cannot walk on heels.
Correct. So it's that again tells you that it is not fitting with the motor radiculopathy or a motor sensory radiculopathy, pure radiculopathy. Okay. You can think because the sensory loss is clearly patchy involvement.
Yes, sir.
Okay. That means what does it indicate? This kind of pattern where you classify
Ganglionopathy.
Possibility of
ganglion.
AD
It indicates a ganglion neuronopathy or can radiculopathy also if some of the fibers are affected. See, ultimately the ganglion is the one which gives rise to the central process. Okay. If the ganglion totally is affected, again you get a total loss. But it may be patchy affection of the ganglion cells. So patchy affection of the roots also can produce that. Okay, so that can totally differentiate. Both can be asymmetrical and patchy.
Possibility of radicular neuropathy, CADP type of presentation, sir.
Yeah, that's a possibility. Say ADP percentage is agreed with that, but that usually does not produce. Okay, nobody can say it is no. That's correct. That's a possibility you have to keep in radical neuropathy, like a CADP, right? So either it's a CADP because of the motor involvement. It cannot be pure ganglion neuronopathy because what? Ganglion neuronopathy should not produce any motor
Motor.
weakness.
Motor.
Yeah. Okay. So what do you like to do in this patient? These are the
No
possibilities.
connection.
Right.
No.
So this conduction was done earlier. I am going to show you subsequent nerve conduction later on, which I did. This was done in April this year. When she was first seen, this is the nerve conduction. We don't expect any loss in the amplitude because there is no weakness in that. In the lower limb, the potentials are not picked up from the ADB as well as from the tibial nerve. Okay. Now, if you look at the FA latency, is not at all picked up from the lower limb. In the upper limb, it's also quite prolonged. In the right median, also it is not picked up with the normal amplitude. Okay.
Madhusudanan sir, the class attended.
Okay. Now the C.
Every Tuesday.
Doctor, can you please mute your mic? Okay. Sural and superficial peroneal, you could not be picked up. So with this finding at that time, what would I have thought? I'll come back to the findings once again. Lower limb, but not potentially picked up from the tibial and conperoneal. Wave latency is absent in the lower limb. In the one nerve, it is absent in the upper limb, other nerves it is prolonged. And sensory potentials are absent in the lower limb.
Radicular neuropathy.
Okay, it's like in radical neuropathy because it's got clear evidence of motor involvement. But what type it is? But you find mainly the axonal type. The potential sensory potentials are gross. There is some demyelination, but see the potentials. Motor potentials are absent. Unless you involved a distal conduction block, the potential is can be lost. And then the sensory potential also lost. That can be due to demyelination itself because of the dispersed potential. Phase cancellation can occur and potential can be absent in demyelination. Anyway, with the available, yeah.
But possibility of nodopathy, paranodopathy, sir, because ataxia out of proportion, amplitude drop, distal conduction block, can all be explained by nodopathy, sir.
No, theoretically you are right, but I'll tell you, classical nodopathy, is the Aman type, which you can see there, it's purely motor. Okay, sensory that does not mean that sensory cannot be affected, it can affect. But there actually what happens is a conduction block occurring in nodopathy. Okay, distally there is good amplitude, proximally decreased amplitude. They don't have a strictly low amplitude alone all through, unless you think that all the nodes distal to the distal stimulation is affected. You got the point. See, nodopathy, what happens is that there is no conduction velocity prolongation. No, you can have conduction prolongation, no dispersed potential. The low amplitude indicates that you are simulating the nodal block is distal to your distal stimulation. Okay. But here all node involvement should be distant. Then only you can explain these things.
Yes, sir. Okay, sir.
Okay. Second thing, this is seen in the upper limb. There is a node of the, there is no weakness in the upper limb.
But sir, the
Yeah.
lower limb, he is able to walk on toes, no? But posterior
Yeah,
is
correct.
zero.
He's
So
walk
how
on
can
toes, but the sensory potential, motor potential is absent. I'll show the
absent?
potential.
So it cannot be an axonal type. It is an axonal type. He should have at least some weakness in walking on toes. No, power is full.
Right. No, what your point is very well taken. So if you remember that, see, the amplitude, the potential, and the power does not go together. To understand the electrophysiology, I will tell you one example. See, to produce a loss of power, there should be decreased amplitude. But the decreased amplitude does not always mean that axon is lost. Suppose you've got a dispersed potential also, you can have a decreased amplitude. But a dispersed potential will not produce any weakness.
Yes, sir.
So it does not go parity. So the decreased amplitude does not always mean there is a weakness. And
Okay, sir.
moreover, so that does not go together. For example, you must have one GVS patient. You find sometimes amplitude may be absent, but patient may be actually have a good power.
Yes, sir.
So I think this can go with something like a CADP, like personally motor and CADP, because it's got CADP demyelination with subsequent axonopathy, you can think. Okay. Right?
Yes, sir.
So this is what are the investigation like to do?
CSF protein, sir.
Okay. CSF protein is 133. And this is the blood sugar value by 13 point, I mean, HbA1c 13.7, just in diabetes. Other things, LFT, those things, renal creatinine sodium normal. Protein electrophoresis was also done normal. What these are the NCV, and the patient has been treated initially with IUM before 5 injections, all based steroids. Then the patient is now coming to you with worsening of the weakness and pain. What will you do now?
Plasma resistor or IV?
Repeat the conduction. Repeat the
Okay.
conduction.
Correct. That's the most important thing. Repeat the conduction. Okay. So this is previously, despite that patient, he continues to worsen. So I saw she was seen by 3rd October this month. And the video shown was the present one. The video which was shown earlier was the present one. It not the video picture, the patient's video was not there earlier. So repeat conduction about it. Now let's take the lipid conduction now, very carefully. Okay, now this is the MNC finding. Lower limb peroneal is absent. TA is picked up. Okay, AH is, EDB is absent. However, potential picked up from the tibialis anterior. Same here also in the AH, in the tibial nerve also. From the AH it is absent. From the gastrocnemius it is picked up. But not fully. Still it is there. Okay. Now come to the motor conduction, sorry, upper limb conduction. There's normal amplitude, mild decrease in the velocity, insignificantly decrease in the velocity. Not up to 40, instead of 45, a mild decrease. Not a significant velocity decrease. In the lower limb, as before, the sensory potentials were totally absent. Upper limbs are normal amplitude. Good amplitude in the upper limb. Remember that she has got loss of sensation of the hands. And look at FA latencies is prolonged in the upper limb where the muscle power was good. And the FA latencies was inelicited. Now you want to see the NCVs once again, I will show that thing. So this NCV, potentials are picked up from the tibialis anterior and gastrocnemius, not picked up from distally. So there is definitely an axon involvement there or a distal conduction. Okay. Then, however, in the upper limb, no evidence of an axon involved. Curry demyelination, we are not very sure about it. This does not come under the does not come under the criteria of demyelination. So then in the sensory content potentials are absent in the lower limb. Upper limbs not.
F, sir.
Pardon?
F, sir.
FA is this FA.
So if there is sensory loss and there is snap present, we have to consider lesion proximal to the ganglion, sir. So we'll see F.
Exactly. So that is the point. So here you have to think of a lesion proximal to the ganglion. Okay, right. That's point number one. Second point, taking the motor.
So
Motor is present plus FA is not elicitable. So that means it's again proximal to the ganglion.
Exactly. May not be proximal to the ganglion. There's no ganglion from motor, but proximal lesion.
Proximal lesion.
Yeah. So what you said, maybe in the root, maybe in the proximal part of the nerve, we don't know. But it cannot be the conventional, the way they are getting it. The distal conduction is, amplitude is good. So at the same time, the FA latency is prolonged. Distal latency is also not very, conduction velocity is not much increased. But gross prolongation, the FA means that there is a demyelinating lesion proximal to that. Okay.
So one doubt, sir. In the lower limb,
please.
we have to consider a radiculoneuropathy, sir. Because in FA is prolonged, there is axonal pattern. The proximal conduction is a bit preserved, amplitude are preserved. Only the distal is involved. So we have to consider radiculoneuropathy rather than a pure radiculopathy, right, sir?
Okay, you are perfectly right. You have to consider radiculopathy for the reason already told you. I'll come to the interpretation. Let us look at the lower limb now. Here, there is a definitely also nerve involvement, axon involvement, because you are not getting any an amplitude in the distal part of the AH and ADB. But that lost amplitude can be due to lesion anywhere from the anterior horn cell down. That does not indicate it should be in the nerve. Okay. If the lesion is in the anterior horn cell, lesion in the motor root, anywhere you can have decrease in the potential. It need not necessarily be in the peripheral nerve. So that does not mean a neuropathy. Now coming to the sensory. The sensory potential, there is absent potential in the lower limb. That indicates what? That means the lesion has to be either in the ganglion or distal to the ganglion. Okay?
Yes, sir.
Yeah, that's all indicate. So taking the whole picture into consideration means that it's not a peripheral problem or like a proximal problem. Taking both together.
Yes, sir.
Okay. Right. So
Like SMP, sir.
yeah, you're right. That's the correct diagnosis. SMB, which can also involve in the ganglion. Pure SMB, CA-SMB cannot explain. But in if you were SAM, if it is only radiculopathy, you won't get absent snap in the lower limb. You got the point. The snaps are also absent in the lower limb. That should not occur in a pure CA-SMB.
Yes, sir. Yes, sir.
But you're perfectly justified telling that because this is not a true compartmentalization. The demyelination should stop short at the ganglion like that. Most of the CSMP you take or CASP you take, you have an enhancement of the not only the nerve roots and the cardiac nerve roots, but also in the ganglion, also in the plexus also get enhancement and thickened. They get thickened also in the periphery. So it's not that it is confined only to the ganglion or only to the proximal ganglion, even though the term CASMB is all given. Actually, it's a combination. They can involve ganglion also. Okay, so sometimes you can pure CSP I have seen with the pure normal potential and absent H wave and this thing can see. But this is not against that possibility. You are still, it's right, say ASMB is there with involvement of the ganglion.
So,
Okay.
so there is a patchy loss of sensation at the hip and other areas.
Correct.
Is it because of the ganglionopathy or because of the patchy radiculopathy?
Both can produce it. See, patchy involvement indicate either a part of the nerve is affected, only branch of the nerve is affected, or it may be some of the ganglion cells. Why it is patchy and ganglionopathy? The ganglion itself is lost, whole of the ganglion is lost, mean that particular nerve, the distribution with the particular nerve. So it is not picking up all the ganglion cells in the ganglion. It may be only some of them will be affected. That is a peculiarity of ganglion neuronopathy. So that also is applicable to the roots also. It is not like a condition where you, like a disc prolapse or something with you're cutting with a knife, with all the nerves are compressed. It's something immunological mechanism which affects only certain ganglions or certain nerve roots, certain fibers in the nerve roots. That is why this kind of a patchy involvement is well described in ganglion neuronopathy and CASP.
And the motor, how can we explain, sir? So additional motor radicals also affected along with the sensory.
Exactly. Motor radiculopathy also is affected. That is why it's got a weakness of the EHL and dorsiflexus. That is what the doctor was telling about CASMB, correct? But the motor roots are also affected, sensory roots are also affected. But it is not a pure CASMB because it's pure CASMB. You can explain the motor, but not the sensory. Sensory loss can occur, but not the absent snap cannot occur. Pure CASMB. That means lesion has to be involved in the ganglion or distal to that. Or you can postulate that sensory loss might have been due to unrelated diabetic neuropathy. That's a different way of explanation. Okay, now let's see this one, objection CADP. The same thing which I discussed, I have put it in an analytical pattern. This already we have covered this particular point, but for completion's sake, now let's take one by one. Where is the site of lesion for such extensive sensory loss? Maybe in the peripheral nerve, maybe in the ganglion and the roots. Now there is severe sensory loss. That's one bit, sensory loss in the upper limb. Look at the NCS, normal sensory potential in the upper limb. Site of sensory loss in the upper limb, proximal to the sensory ganglion in the upper limb. You have already mentioned that particular point. Or it can be at the ganglion and distal to the ganglion, the lower limb. Since the lower limb is considered because lower limb potential is absent. So it cannot be in the roots. It has to be in the ganglion or distal to the ganglion lower limbs. The lower limbs, it is symmetrical sensory loss for all modalities below the knee, unlike in the trunk and upper limbs, where it is asymmetrical and patchy. Could this be due to distal sensory polyneuropathy due to diabetes? Quite possible. That one cannot deny that possibility. Now let us see the site of sensory loss in the lower limb. So far we discussed with the upper limb. How to explain the impaired vibration over both anticipatory spine with spared vibration in the knee? So that cannot explain with the sensory neuropathy in the lower limb, in the due to diabetes. So again, there is a problem in assuming that it is diabetes mellitus in the lower limb. Because again, it is not fitting in the strict distal symmetrical pattern because anticipatory spine is also lost. So possibly the sensory loss in the lower limbs may also be due to the roots or ganglion. Now let us analyze the motor weakness. So it's got both dorsiflexus of the ankle and EHL is weak. Lesion can be anywhere from the anticonceptive routes, then anything anywhere side is possible. Could be motor peripheral neuropathy since weakness is distal symmetrical. Now, weakness, let's say analyze the weakness of dosification angle AHL. Look at the amplitude of the TA. It's a really good amplitude. At the same time, the FAV latency is absent, totally absent. That means there is some problem in proximal. Otherwise, this should not be absent. Some demyelinating lesion proximal. It may be in the roots also. It may be in the proximal nerves also. But taking the sensory loss due to a sensory radiculopathy, this is also possibly a motor radiculopathy proximal to that, responsible for the FA. Okay. So that 2 points were most likely motor sensory radiculopathy. See, look at the LFA that I'm comparing with this is even in the unaffected nerves, without weakness, they've got a prolonged evidence of demyelination proximally. Okay, so taking these two consideration, that means the motor weakness is again probably due to a demyelinating pathology proximal. Now look at the FA. If it is prolonged even in the limbs without weakness, that means the proximal demyelination may be in the roots are proximal to the proximal stimulation. With the velocity is only minimally increased and decreased, but a gross prolongation of the FA. Then the surprise already been discussed. So what else will you like to do? HN SCP. So both were inelicitable from the lower limb. I should have done from the upper limb, but that I did not do. I should not have also done from the upper limb, from the tibia. But volume is also in because remember that in H reflex and does not depending upon your the fibers which do H reflex is the one carrying the reflexes. That is different from that carrying the joint position sense. Okay, so you can definitely do an H reflex even though there is a snap absent in the lobe. Now, this question, normally, logically, what will you think? Can this absent SSC be attributed to absent snap means, should
No.
you do that? Yeah, you should not get. Okay.
Yes.
Yeah, but you can get. Fun because you are now stimulating directly the tibial nerve with the popliteal fossa, no distal to that. The ability of snap is due to distal stimulation. When distal pathology still absent, a snap can be absent. This is from the lead. Then I wanted to search whether it's possible or not. Can H reflex be present in the presence of absent snaps? It is possible for H reflex to be present even when snaps are absent. This occurs because H reflex specifically tests the integrity of the afferent fibers primarily related to the muscle spindle pathway, which may still function even if cutaneous large myelin fibers, mainly response snaps, are damaged or not functional. Therefore, in conditions where there is a proximal sensory pathology such as radiculopathy or selective involvement of certain fiber types, H reflex can sometimes be preserved despite absent snaps. Although this is not always the case, it depends on the site and nature of the nerve lesion. Okay, another point, it is done at the tibial nerve at the popliteal fossa. So clinically, it's got a sensory loss only distal to that, but we are stimulating proximal to that tibial nerve. Okay, I think this. So what else you need now? What do you like to do?
CSF study.
CSF already done.
Demyelination, no, sir. So,
Pardon?
so it is a demyelination.
Yeah.
So already methylprednisolone only was given, no, sir.
Yeah.
So because
So
it's a
MRI.
diabetic, we cannot give again methyl. We can give plasmapheresis or IVIG.
Okay. Right. Okay,
Contrast
but
MRI of the
yeah,
roots.
right. You have to confirm, no, this is all post-date from your radiology. Sorry, NCA studies, we thought it's most likely ganglion neuronopathy. We thought it could be a CAS, CSMP. So we have to again confirm by contrast MRI. Okay. So the contrast MRI was done. I will show the contrast. This is it. I'll show all the films and show the abnormal finding also. This is a T2, does not show much of an abnormality. Axial. There is some enlargement of the ganglion, you can see there. It is slightly prominent. See, the ganglion is slightly bulky. Again, I'll show the axial cut ganglion. See, this is a ganglion which is slightly bulkier than normal, symmetrically bulky, more on the left side. And this is the coronal cut. Showing the enhancement in the stereometry hyperintensity even in the plexus on both sides. But more importantly, what you look at the contrast study. See the ganglion is enhancing and the nerve roots is enhancing. I'll show the static picture later on. So sorry, I did not enlarge. I think just 1 minute I will make it enlarge. I forgot to do that. I want to do it today morning, somewhere that I can do.
But it is seen clearly, sir, without enlargement.
You can see, no?
Yes.
I will say little more.
You can see.
Yeah. Welcome back. Now you can see.
Yes.
This one I will show you. See the enhancing ganglion here, bilaterally and the roots. I'll show you. I'll come the picture. Yeah. This is the thickened, enlarged ganglion. You can see the enhancement of the ganglion there, and the roots are in the middle part. Again, you can find out the ganglion and the roots is enhancing. Again, thickened root and enhancing thickened roots. Again, multiple thickened roots below that level. So they confirm that lesion is there in the roots also. And ganglion also is enhancing. So as told before, it is not only pure CSMB, the ganglion has to be implicated because of the absent snap in the lower limb. So it's a CSMB encroaching, also including in the ganglion neuronopathy. So it's essentially a ganglion neuronopathy with associated root, which is involving both sensory and motor root.
What is
Either
the, sorry, sir.
Yeah.
What is the what will happen to the SSCP in this case, sir? Is it
SCP is absent the lower limb.
absent? Okay. Here we have to do the contrast study in the lower limb as well as in the upper limb.
Well, actually, it should be into the upper limb because upper limbs are also clinically affected. So if you do that, you can define enhancement of the root and the brachial plexus and the cervical root cell will enhancing. But the problem is that the patient has to shell out that much out of money, So that is why restricted only to the lower limb.
Okay.
Yeah, our idea is to demonstrate. It is demonstrated. Okay, then why do you want to show? I mean, it can ideally should be done, but in the interest of the money expenditure, I did not do that. So you can call CVSMB with either sensory diabetic retinopathy, that's possible, or CSMB with ganglion neuronopathy. The latter is more likely a possibility here. Ganglion neuronopathy can explain the absent snaps in the lower limb, and we need not involve the associated and related diabetic neuropathy. Okay, so that is the condition this patient.
Brachial plexus study was normal, sir. Brachial plexus study
Brachial-
NCS.
Brachial plexus study was not, I mean, even NCS.
NCS, sir.
NCS I showed the upper limb contraction, no?
Brachial plexus like axillary and suprascapular nerves.
No, that was not done because that is not clinically effective. No, that's what I did not do. Moreover, it's a sensory finding which is in the upper limb normally. So sensory condition was given.
So the medial anti-brachial cutaneous MABC and LABC are also not done because that area was showing sensory loss, sir.
No, sensory loss is not only there. In the shoulder downward, it is lost. It is not at all confined to the nerve pattern at all. If it had been in the nerve pattern, then brachial plexus study is important. Here it is entirely patchy. Here, so in the neck, it is lost. Sensory loss is the neck also. Again, favoring more like a radiculopathy in this patient. Radiculopathy or ganglionopathy, whatever it is, you can.
Is it a purely immunological or is it a paraneoplastic or vascular?
There are many etiologies for ganglion neuronopathy. One of which is paraneoplastic, vitamin B12 deficiencies, toxic, drug-induced. Many things are there, HIV. But here it is 7 years duration. Totally 7 years. So that's why I did not consider drug-induced or paraneoplastic. Less likely in this, most likely immune-mediated.
Diabetes itself, it is more, incidence is more.
Yeah, correct.
ANA profile was done, sir, in this.
Yeah, it was done. It was done. I think I showed that ANA profile was done.
Sir, duration 7 years, sir.
7 years, 7 years.
So usually the etiology for the radicular CIS, MP and ganglionopathy are entirely unrelated, sir.
No,
Usual
they are
causes-
same etiology, almost the same etiology.
So that
this-
neck pain is related to, sir? That neck
To the
cervical pain?
involvement in the pain fibers or the pain ganglions and the small ganglion cells in the cervical cord, the cervical region, or the nerve, small fibers itself.
Sir, in ganglionopathy, you get a degeneration of the posterior column in MRI, no?
Yeah, they can have. In CASP also you will have. Because what happened means the ganglion has got a peripheral process and a central process. When the ganglion cells die, not only the peripheral process die, the central process also will die. So what will happen, after some time you get a hyperintensity in the dorsal column. Okay.
So for this patient, it is not there. For this patient, the dorsal column hyperintensity is not there.
It's not, no, it is not there.
Okay, sir.
That need not be all there all the time. It will be there all the time. And this can also occur with the CASP also. Because CASP is proximal to the any lesion proximal to the ganglion. Be it in the ganglion, be it in the dorsal root, be it in the cord itself, you can have hyperintensity. Just like our subacute combined degeneration.
So CASP is basically a demyelination, not an axonal. So
No, that depends. No, that etiology can be very, but ganglion neuronopathy is actually axonal only. If the central process is affected, it becomes axonal.
That in ganglionopathy you can get, but in CISP it is a demyelinating disorder. Can you get such hyperintensity in the dorsal column?
No. You will get only if it is the axon is affected. So demyelination does not always mean that the axon should not be affected. It can get affected, axon can be affected. For example, classically, if you take MMCB, multifocal motor contraction block, invariably they will have wasting of the muscles, even fasciculations can occur because the axon get involved later on.
Okay, sir.
Yeah.
Sir, here, what immunotherapy you gave, sir?
Rituximab.
Rituximab, okay, sir.
Because I sent for this antibody as well as the chickenpox vaccination I given first dose. I should to confirm at 1 week for the rituximab. She did not have chickenpox earlier, so I gave me a vaccination.
So all patients you give chickenpox vaccination before rituximab, sir?
I asked the history. If the patient already had chickenpox, I don't give vaccination. If the patient did not have chickenpox earlier, I vaccinate and then give the rituximab.
Then 4 weeks later only we can give, no, sir, rituximab.
Ideally 4 weeks, but after the first dose, 2 weeks later, I usually give because we can't wait, no. So that
Okay, sir.
ideally it should be 4 weeks.
So you give influenza vaccine, pneumococcal vaccine, and for those patients with
No,
inflammatory.
only chickenpox vaccine, and then look for this hepatitis B core antibody. If it is negative, I can definitely go for this thing.
So pneumococcal and influenza
No,
not
usually we don't do it like that.
Okay, sir.
See, we have been giving for how many years we have been giving rituximab. The complication is, the infection is much low. Only one patient who had permanent hepatitis, this thing, chickenpox infection, following rituximab. Otherwise, none of them had any serious problem at all.
Sir, in these cases, just before the rituximab, should we start on MMF or Visalon?
Yeah, that's a good question. Theoretically, you are justifying MMF and or azathioprine. But I'll tell you, all the cases which I have seen with the ganglion neuropathy and CSP, they did not respond to MMF azathioprine. They responded only to rituximab. But your point is well taken. This information, because I was giving, as you said, MMF earlier, the patient did not respond. Murthy sir from Hyderabad used to tell me that, although you say for rituximab, that they will not respond. In my experience also, that's what he said. So I learned this point from him only. Then I started trying this and they responded.
Cyclophosphamide also we can try, sir. Cyclophosphamide.
If it is not responding, so next line is cyclophosphamide. But remember that CASP and CASP and ganglion neuropathy, their improvement is not rapid as you suspect there can be CADP. It is very slow over years.
Sir, in those cases, is it we can just continue this rituximab alone, like for the first dose, and then after 2 weeks and 6 months, like that, without using any immunosuppressants?
And other immunosuppressants which I am receiving can be tapered up and stopped. And once this takes effect, you can continue with rituximab alone, monitoring the CD19 cell count.
So you check CD19 only, or you check CD19 and CD20 both?
Usually, ideally, 20 is enough, but 19 is routinely done, easily available. That's why we do it.
So all the neuronal antibody profiles were negative. Like anti-Q, all those things, sometimes paraneoplastic and all, even though the duration.
Paraneoplastic I did not know how to do because duration is so long, so very unlikely paraneoplastic.
Okay.
7 years.
What about the CADP panel? Only 3 antibodies.
You mean that this one, neurophysin antibodies?
Yes.
I did not do that.
But అది చేయదాలో even if we give, we do, if it is positive, we are giving rituximab. So you have already given rituximab.
Okay. No, the thing is that ideally, it's not that we cannot do, we should do. And ganglioside antibody also you can do. But all means the patient, once we know that diagnosis is there, then we can need not go home, spend much money on the patient side.
But one doubt, sir, why is that the patient worsened with steroid? Initially, steroid was given, no?
Yeah, did not respond with steroids, he started worsening again. That's what I said initially, that these people, unlike the classical CADP, they did not respond to this thing, they worsened on it. Some of the CADP also didn't respond to steroid. So while I was in Amrita, I've seen patients who had to be given plasmapheresis, endoxan, everything has to be given. Still, she did not respond. All things were tried. Classical CADP. It all depends. Some of them do respond to steroid, only steroid.
Plasma exchange also. No?
Yeah, plasma repeated that particular to prepare plasma exchange, IVIG, then rituximab, all were given in that patient simultaneously. Because after the coming, every time coming the relapse with the quadriplegia, it can be done.
Whether this neurophysin antibody has to be done because they present like a nodopathy, paranodopathy, sir, no?
Yeah.
So here the presentation is different, no? So neurophysin.
No, the neuropathy antibody presentation is quite varied and need not necessarily be nodopathy because that presentation can be one of the CDP variant itself can present can be due to neuropathy antibodies. In these neuropathy antibodies implicated in both not only central and peripheral demyelination, central and CCPD. I have presented one case before.
Yes, sir.
Where there is a central demyelination and peripheral demyelination.
But not reported with CASMP, no?
No, I have no idea. CSM, no idea what CSM.
Central means spine cord lesions or brain lesions.
The patient which a person had a brain lesion. They must like lesion.
So the neurophysin antibody, we asked for only 155 or we have to do everything?
In the panel.
Panel full.
Yep. Okay, shall I go to the next case? Or you want to stop?
So for this
But,
patient,
Next case.
Yeah, please. Yeah.
so for this patient, ganglioside antibodies were done?
Not done.
Nothing. Only the which one was done, sir? Only the Q and
No antibody was done because the diagnosis clearly CASP or CSNP or only neuronopathy. The treatment is rituximab. It is immune mediated. I know it's immune mediated. It cannot be anything else. So whatever the antibody comes, the treatment is same. Because that's not going to change the treatment modality.
So did she respond very well to rituximab?
They should respond. But the 3 or 4 cases which I had, they respond only to rituximab, and that too, it is not immediate. It takes some time for that improvement to occur.
So still on follow this patient.
Yeah, right.
Thank you.
steroids will be continuing or not continuing? Because
So we can stop that once rituximab is started, steroids will be tapered and stopped.
will the plasma exchange work for this? Or
No, when it is a bit difficult, long-term treatment. The treatment is long-term. Plasma exchange possible, but not practically viable. Okay, shall I go to the next case?
Yes, sir. Thank you.
Yes, sir.
Okay. Yeah. This is a story of a 10-year-old girl. About 2 years back, that is at the age of 8 years, patient was noticed to be having dropping of objects on the right hand, and she was noticed to have abnormal movements of the tongue and involuntary movements of the right upper limb and trunk. Something like a choric movement. MRI brain taken at this time was reportedly normal. This is MRI done at this time with involuntary movement. It's a normal MRI. This is a contrast MRI. She was admitted in the local hospital with this involuntary movement. And this is a discharge summary. There's chorea and all milkmaid grip and everything were present. Coming to the reports, ASO titer was normal, CRP was normal. The investigated thoroughly, LFT was done. Then serum calcium, magnesium, phosphorus, thyroid functions are all normal. Anti-DNS serum B was negative. Anti-nuclear antibody factor was also negative. Thyroid antibodies negative. Echocardiogram considering the possibility of a rheumatic chorea negative. And NMDA was also done negative. And the other findings, echocardiac normal, MRI study showed no significant abnormality in the brain. CSS study protein 13, NMDA antibodies were negative. Anti-DNase serum was negative. Nuclear antibodies, all negative. So ESC abdomen, no significant abnormality detected. This was done before. The patient was given Serenase, valparin, chrono. Think most likely chorea secondary to autoimmune encephalitis, maybe rheumatic chorea itself, when though this antibody ASO titer was negative.
Ceruloplasmin,
Sorry, negative. Everything, serum, copper, everything was normal. Then what happened is, her involuntary movements subsided over 2 months. 8 months back, she developed episodic hemicranial headache associated with photophobia and vomiting, which used to occur initially once a month. Subsequently, the frequency increased to almost daily, even on treatment with anti-migrainous treatment. Since her headache and vomiting persisted even after change of medication, an MRI was taken at the insistence of her mother. The doctor did a classical history of migraine. Previous MRI was normal. So then mother said, no, I want why his headache is subsiding, you take an MRI. And that MRI showed some abnormality in the brain. And the parents were told that she had occlusion of the vessel and referred to major hospital. The MRI done with the patient resistant headache is suggestive of migraine on 23rd February is now going to show now. This is the MRI there. This is a diffusion sequence. You can see the hyperintensity diffusion restriction in the left insular cortical region and also the adjoining white matter, subjacent white matter. This is the picture showing the diffusion restriction. Something like an infarct, but not fitting with the vascular territory. That is a T2 hyperintensity. This is the flare hyperintensity. Not the typical one as you see in melas. The melas usually cortical ribbon-like. This is SWI. This contrast showed some patchy enhancement over that area. Nodular enhancement. However, the imaging of the vessels were normal. Spectroscopy was done, but possibility considered was that of a mitochondrial disease because of the chorea and the migraine. And this is the normal, from the normal area, that is lactate peak is not there. Because usually mitochondrial expect to do an MRS from the normal area where lactate should be elevated. But here the lactate peak is not there in the normal area of the brain. But the affected area lactate is elevated, but the NAA choline ratio is good. So that means most likely an infarct or something has happened at that area where the lactate is increased. So this is the area where the lactate is increased. So other investigations done at this time, hemogram normal, vitamin B12, this is when the patient had headache. Vitamin B12 done normal, anti-nuclear antibody normal, homocysteine was mildly elevated, 23.9, thyroid functions normal, anti-nuclear immunofluorescence, that came as positive. But subsequently that also negative. Angiotensin beta normal, CSF repeated 61, cytology normal, homocysteine normal. There she was put on medication and advised to undergo serial INR imaging and the headache subsided. Okay. The story does not end there. 4 weeks later, 10/4/23, patient noticed to have involuntary movements in the left upper and lower limb with consonance in walking and dropping of the objects from the left hand. That is when the patient presented to me. This is the time that is a first initiated generalized chorea, not right-sided chorea. Then she had migraine. Now it's come with the left-sided chorea.
ഇടത്തോട്ട് നോക്കുമ്പോളെ നേരെ നോക്കിക്കുമ്പോൾ ഈ നാക്ക് നീട്ടിക്കൊണ്ടേയിരിക്കേ.
You can see the shoulder shrugging in
കാറ്റിട്ടിരുന്നേ.
between. No typical jack in the box, but occasionally it comes out here. Look at the left upper limb and left upper limb and lower limb.
സംശയത്തിലേക്കാണ് നമ്മളെ അനിയും വരുവാനി
So hemichoria on the left side.
ഏറ്റവും പ്രധാനപ്പെട്ട കൂട്ടുകാരുടെ പേരെന്താ? മറ്റേ കേന്ദ്രീയില് നോക്കട്ടെ ഇരിക്കല്ലേ.
Rest of the CNS examination was normal, no weakness. Randar was negative. The rest are all normal.
Antiphospholipid antibody or
APLN.
Yep, correct. So rheumatic chorea, panda, these are the things you have to keep in mind, such like caudate nucleus, metabolic Wilson disease. So when the MRI done, when the patient is admitted the present left-sided chorea, there is no fresh lesion. The lesion which has been there earlier has improved. This is the lesion which is then that has become decreased in size. Previous lesion was found to be decreased in size despite the development of new symptoms. So what is the diagnosis like? Anyway, you already
Primary
this,
epilepsy.
yeah, this I had shown some time back. I tried a similar case, same case. ANA profile was negative. This is MDHR gene mutation was negative. ANA was positive. TM was negative. Antinuclear antibody positive. Then this one, this IG, the anticardiolapin antibody, the IgM was elevated. Beta-2 glycoprotein was increased, and APLA, this lupus anticoagulant, was strongly positive. So the point is that this is one condition which you often overlook. We don't look for any lupus anticoagulant patient coming with a young person coming with a chorea, especially shifting chorea, recurrent chorea. You have to think this condition might, especially in person coming with episodic headache also. So patients got on IVMP followed by oral steroids and aspirin. Just after 5 days of IVMP, her chorea is dramatically decreased. It's regularly coming for follow-up for the last 2 years now. No further neurological symptoms. He continues to be on oral steroid and equaspirin. Equaspirin I-VAR.
equaspirin steroid. How much is steroid?
Not equaspirin, warfarin. Warf means vitamin K antagonist as well as steroid, small dose steroid. So that's the story of the patient.
This aplacin, how is it done? Is it a panel or isolated test?
These are in fact, these are the tests which is done already. This lupus anticoagulant, beta-2 microglobulin, as well as the cardiolipin antibody.
Sir, what is the nature of the CNS shadows? Are they vasculitic or something else? Demyelination?
That's an infarct. Because it's a lupus anticoagulant condition which can produce an infarct in the brain. That does not fit in with the vascular territory. Vascular large artery territory, yeah.
If it is in fact the shadows or the scars, gliosis should be there.
There is a gliosis there. After the second MRI showed a gliosis. I can show I'll show the MRI, second one. This is the second one. You can see the glycosis there.
Okay, sir.
How long we should use the steroids, sir, in this case?
I don't know. Lifelong, probably lifelong. Both these things.
Only anticoagulation is required, or you need to give steroids.
No, she's on very small dose of steroid now. Is around 5 milligram alternate, 5 or 7.5 alternate day, and bar. Because the parents were insisting, why can't we stop the medication and all? I was not sure to stop it. And literature, I asked Dr. Shailaja also, she also said, do not stop. Because sometimes they can, when they stop, they can go into catastrophic strokes and complications. The literature also, I'll show the literature also. I think I'll skip this criteria and all. So the clinical criteria is vascular thrombosis and pregnancy morbidity. Then lab criteria, lupus anticoagulant present in the plasma, anticoagulant level more than 40, anti-beta protein. The cerebral involvement in APS is common, characterized by different clinical manifestation. So ischemic event, epilepsy, dementia, cognitive, these are all the things which can occur described in antiphospholipid antibody syndromes. The chorea is reported to be a rare manifestation patients as SLE and APS, but strongly associated with the presence of antiphospholipid antibody. This is sometimes they can mimic multiple sclerosis, like in APL syndrome. So if you look at the picture, definitely you think it's MS, but that can fit in, can mimic. But again, it's due to the vasculopathy. So this is the complication which one should be aware of: catastrophic antiphospholipid syndrome. This is called, it's a very rare severe variant of APS. It is characterized by accelerated widespread small muscle occlusion in the presence of APL antibodies, usually in high titer. About 1% patients APS develop this catastrophic form. CAPS appears in patients with primary APS, SLE, lupus-like disease, as well as autoimmune disease. In almost half the patients' CAPS, it was the first presentation of APS. Infection, surgery, oral anticoagulation withdrawal, some drugs, obstetric complications, and neoplasms are the most common discrete precipitating factors. So they clearly mentioned oral anticoagulation withdrawal can sometimes precipitate CAP syndrome. So that is where the fear we all have. Pulmonary neurological renal involvement are the most common presenting manifestation of CAPS. So I am not mentioning the name. One of my colleague working in my hospital, his wife died of this thing, CAP syndrome. So that's a story of this.
So how much warf was given, sir?
That depending upon the INR. Depending on the INR, they made it. I don't know. I forgot the exact value now.
Sir, do MTHFR mutation for all young strokes?
Pardon?
MTHFR mutation is done for all young strokes, or when the homocysteine is elevated only? Or?
No, because I did not know. It was done from the outside. When no other thing is done, no obvious. So we do all the things. Because chorea is an uncommon presentation of this thing. This syndrome. APLS syndrome. That is what they did not suspect it. See, this is in the literature also, they say that, see, reported to be a rare neurological complication. The usual thing is migraine, seizures, vascular accident, MS-like presentation.
The childhood psychos also usually.
Yeah, yes, psychosis. Correct, exactly.
Actually, it gets complicated when the psychiatrists give antipsychotics and they develop movement disorders. It becomes so.
Right, perfectly right. Okay. Can we stop?
Sir, in childhood migraine, should we work up for APLA?
Not at all. Because in that case, we will be investigating all cases of migraine for apply now. Not necessarily. That's my personal idea. If you ask me why not, you can. But because migraine is so common, that apply is so rare, that if we can start doing investigations, that's the end to it. Some other commons, like for it's a migraine, here the patient's got a chorea, recurrent chorea. There you are justified. And MRI shows some finding in the brain, implant-like presentation. There you should.
During pregnancy, we have to give low molecular weight heparin throughout the pregnancy.
I must be,
Yes.
I don't know. Yeah.
Yes, sir. Yes.
Yeah. I'm not sure about it. Yeah, you're right.
The moment they got married and got conceived, WARF to be changed.
Stop changing. Yeah,
Yes.
correct. Yeah.
Ecosprin and then aspirin and low molecular heparin, they will put
Correct.
throughout
Yeah,
the pregnancy.
Now I remember, because warp is contraindicated during pregnancy.
Yes.
This patient doesn't require aspirin, only warfarin and steroid.
No, not ecosprin. Warp only steroid. If I wanted to tell you warp, if the ecosprin came to my mind. It is not ecosprin, she is on warp and this thing.
Okay, sir.
Okay, then.
Okay, sir. Wonderful case. Thank you.
Thank you, sir. Thank you very much,
Thank you, sir.
Thank you.
Good night.
Good
Thank
night.
you, sir. Thank you. Good night.
Thank you.
Good night.
Good night.
Good night.
Good night, sir. Good night, sir. Good night.
Yes, sir.
Good night.
Good night.